Can microdosing psilocybin, which is the active ingredient in magic mushrooms, actually help ease the intense psychological and existential anxiety related to the proximity of death?
Which is a huge question.
Huge. We're looking at 20 patients in Ottawa, Canada, who were given a 3-week escalating microdose of this compound. We're going to look at whether it's safe, its potential to replace traditional anxiety medications, and crucially, we're going to look at the hard data without any of the usual hype.
Right, because the hype is everywhere right now.
Yeah.
But to understand why researchers are even looking for alternatives to traditional treatments, you have to understand the sheer scale of the problem here.
It's staggering, isn't it?
It really is. If you're diagnosed with an advanced, incurable illness, the statistics are just heavy. Roughly 35 to 50% of those patients experience severe psychological or existential distress.
Wow, so up to half of them.
Exactly. We're talking about profound depression, debilitating anxiety, and a complete loss of meaning or purpose. And the harsh reality is that standard palliative interventions for this specific type of suffering are simply lacking.
Yeah, I mean, you look at the standard toolkit, right? Antidepressants, anxiolytics, the daily pills that millions of people take for generalized anxiety or clinical depression.
Right.
And the researchers point out that there is very limited evidence showing they actually work for patients at the end of life.
Because it's a completely different context. Standard antidepressants like SSRIs, they're generally designed to address long-term neurochemical imbalances.
Right, the chemical side of it.
Yeah, but existential distress in palliative care isn't necessarily a chemical imbalance. It is, frankly, a very rational psychological reaction to facing your own mortality.
It makes total sense. And then there's the timeline issue, too. The way I kept thinking about starting a terminally ill patient on a traditional antidepressant is that it's basically like planting a slow-growing oak tree in your backyard when your lease on the house is up in 2 months.
That is a great way to put it.
It just makes absolutely no sense for the timeline. These traditional meds take sometimes 4 weeks to even begin altering the brain's chemistry enough to show an effect.
Yeah.
If a patient has an estimated prognosis of 1 to 12 months, they do not have weeks to wait around hoping a pill kicks in.
Exactly. And that is assuming they can even tolerate the medication. Many palliative patients actively avoid these traditional drugs because of the unwanted side effects.
Oh, right. Like what?
Well, you're talking about nausea, profound fatigue, and emotional blunting. When you only have a few months left, the last thing you want is to feel emotionally numb to your family.
Oh, absolutely.
Even psychotherapeutic interventions like cognitive behavioral therapy, they've shown modest results, but very poor durability in these patients.
So that's why medicine started looking at psychedelics as a potential replacement. And you might be wondering, if you're listening to this, why not just give them a full dose of psilocybin?
Right, the macrodose.
Yeah, we've all seen the headlines about macrodosing psychedelics, giving someone a large dose that induces a full hallucinogenic trip. Recent meta-analyses show that actually does work for treating depression in people with life-threatening diseases, right?
If we connect this to the bigger picture, it does work, yes. But there is a massive logistical and physical barrier there.
How so?
Macrodosing requires weeks of clinical preparation. The patient then undergoes hours of intense, supervised psychotherapy while they are actively hallucinating. It's a profound, often exhausting psychological journey.
And it's physically taxing too, isn't it?
Oh, highly taxing. A full macrodose frequently causes acute physical side effects, like severe nausea, dizziness, and significant spikes in blood pressure and heart rate.
Wow. Okay.
Now, imagine a palliative patient who is physically frail, perhaps dealing with advanced cancer, ALS, or organ failure, subjecting their body to that kind of cardiovascular strain, not to mention the operational delay of setting up a supervised trip. It's simply not feasible for most of them.
So, if the intense hallucinogenic trip is what causes the physical strain, the idea is, could you just sneak under the brain's radar?
Exactly.
Like give just enough of the compound to stimulate the receptors without triggering the cardiovascular spike or the hallucinations. That's the core hypothesis of the trial, right?
It is.
Can a daily microdose give the symptom relief of psychedelics, the easing of that death anxiety, without the heavy burden of a macrodose?
But here's the challenge. You can't just hand out a powerful serotonergic compound to highly vulnerable patients. You need strict guardrails. You can't just let anyone into a trial like this.
Right, the exclusion criteria. They screened 34 people, but only let 20 enroll. And who they kept out tells us a lot about how psilocybin actually works in the body.
Definitely.
For instance, they immediately excluded anyone with a history of psychotic or bipolar disorders.
That's standard for any psychedelic trial. Even at a microdose level, these compounds alter perception and mood, which can tragically trigger manic or psychotic episodes in predisposed individuals.
That makes sense. But because this is a palliative setting, they also excluded anyone with active delirium or moderate to severe dementia.
Yeah, for obvious reasons.
Right, which makes total sense. If someone's grip on reality is already slipping, or they're experiencing confusion at the end of life, introducing any kind of hallucinogen could turn a peaceful room into a nightmare.
Precisely. They also had strict physical exclusions. Patients with severe or unstable physical symptoms were out. Anyone with a palliative performance scale score under 30% was excluded.
What does that score mean exactly?
That score essentially indicates someone who is completely bedbound and unable to perform any self-care. They also excluded patients with central nervous system cancers. Tumors in the brain or spine can make neurological responses to psychoactive drugs completely unpredictable.
Okay, let's unpack this because the part of the exclusion criteria that I found most revealing was how they handled other medications.
Oh, yeah. The drug interactions.
Test if psilocybin has the potential to replace traditional meds. They had to be incredibly careful with patients who were already on traditional meds. It really highlights how heavily medicated this population is.
The pharmacological interactions are a massive hurdle. Psilocybin acts primarily on the serotonin receptors in the brain. Serotonin is often called the brain's mood regulator.
Right.
So if you introduce psilocybin, which mimics serotonin, while the patient is taking other drugs that also alter serotonin levels, you risk a condition called serotonin syndrome.
Can you break that down for us? What exactly is happening in the brain there?
Sure. Let's look at an SSRI, a standard antidepressant. SSRI stands for Selective Serotonin Reuptake Inhibitor. Normally, your brain releases serotonin to send a signal, and then it cleans it up or reuptakes it.
Okay, so it recycles it.
Exactly. An SSRI blocks that cleanup process, leaving more serotonin floating around in the brain to boost your mood.
Okay, so if the SSRI is already stopping the cleanup, and then you add psilocybin, which is flooding those exact same receptors, it's basically a chemical traffic jam.
That is a great way to picture it. It's a severe neurological traffic jam. The receptors get completely overwhelmed and the body reacts violently.
Wow.
Serotonin syndrome can cause high fever, severe tremors, rapid heart rate, and in extreme cases, it can actually be fatal.
So the researchers had to outright ban patients who were taking MAOIs, lithium, tramadol, or atypical antipsychotics.
Yep, completely banned.
And even those standard SSRIs were heavily restricted. Patients could stay on them, but only under very strict maximum dose limits. For example, if a patient was on, say, citalopram, they couldn't be taking more than 15 milligrams. If they were on citalopram, no more than 30 milligrams. So with all those safety nets firmly in place, 17 patients actually started the intervention. The protocol was a 3-week journey. Week 1, they took 1 milligram of oral psilocybin daily. Week 2, they bumped it to 2 milligrams. And week 3, they went up to 3 milligrams.
And it's worth noting the human element of clinical trials here. They originally planned a 4-week trial with an even slower, more cautious start.
Oh, really? I didn't catch that.
Yeah, they actually had to amend the protocol mid-study. The first few patients found the initial doses way too low. They were getting frustrated by the delay and feeling any benefit. And when you are at the end of your life, a week of waiting feels like an eternity.
Yeah, of course it does.
So the researchers tightened the timeline to get patients to the effective doses faster.
And out of the 17 who started, 13 completed the full 3 weeks. I want to jump straight into the findings because the raw numbers they published are pretty striking.
Very striking.
Of those 13 who finished, 69%, so 9 out of 13, reported a meaningful global improvement.
That's based on the Patient Global Impression of Change score. It means they self-reported feeling moderately better, or a great deal better.
But the metric that really stands out is the demoralization scale, too. This is a tool specifically designed to measure existential distress, that profound loss of meaning and purpose we talked about earlier.
Right.
72% of the participants reported a clinically meaningful improvement on that specific scale.
We also saw a 50% reduction in depression scores for over a third of the patients, and a 50% reduction in anxiety for over half of them.
Okay, wait. Before we just read off these stats, we have to talk about how a microscopic dose of this compound is actually achieving that.
Right, the mechanics of it.
Yeah, if they aren't tripping, if they aren't having these grand mystical visions that macrodose patients report mechanically, what is the microdose doing to ease that existential dread?
It's a great question, and It comes down to a network in the brain called the default mode network, or the DMN. You can think of the DMN as the brain's ego center or its rumination engine.
Okay.
It's the part of the brain that's active when you're thinking about yourself, your past, your future, and your mortality.
So for a person with a terminal diagnosis, that network must just be stuck on overdrive.
Exactly. The DMN becomes hyperactive. The brain gets stuck in this rigid, looping pattern of existential dread and anxiety. Think of it like a sled track in the snow.
A sled track.
Yeah, if you keep going down the exact same path of fear and dread, that groove gets deeper and deeper until you literally cannot steer the sled anywhere else.
Ah, I see. So how does the microdose affect that?
Psilocybin, even at very low doses, has been shown to subtly quiet the default mode network. It disrupts those rigid neural pathways just enough to allow new connections to form.
Interesting.
To use your snow analogy, the microdose acts like a light, continuous dusting of fresh snow. It doesn't completely bury the track. The patient still knows they're dying, but it softens the grooves just enough so they can steer their thoughts in a different direction. It gives them cognitive flexibility without blasting them out of reality.
That makes so much sense. And here's where it gets really interesting, because the adjustability of the microdose seems to be a huge factor in why it's feasible for this population.
Absolutely.
There is a specific anecdote in the study that really brings this to life. They noted that most patients found their sweet spot of benefit at the 3 milligram dose. But there was one patient who weighed only 37 kilograms, which is about 81 pounds.
Yeah, when you're dealing with advanced illness, severe weight loss and physical wasting are very common.
Right. And when the clinical team bumped this 81-pound patient's dose to 2 milligrams, the patient got lightheaded. So the team simply dropped them back down to 1 milligram daily.
And it worked.
It did. That patient successfully completed the study and had a good emotional response at that lower dose.
Wow.
You can't do that with a massive one-size-fits-all macrodose.
That adjustability is exactly why microdosing is so appealing from a safety perspective. And safety was a primary endpoint of this phase 2 trial.
And the results were good.
The results on that front are incredibly reassuring. Out of 18 total adverse events reported across all patients, 14 were just mild, like the lightheadedness you mentioned, and 4 were moderate, like temporary anxiety.
And there were no serious adverse events.
None. There were no cases of delirium, no cases of that dangerous serotonin syndrome we discussed, and no concerning spikes in cardiovascular vitals.
So the blood pressure was fine.
Blood pressure and heart rate stayed completely within acceptable limits. It proved to be a highly tolerable regimen. In fact, of the 8 patients who experienced major benefits and survived to the 4-week follow-up, 6 of them requested to stay on the psilocybin in an open-label extension. They actively chose not to give it up.
Okay, listening to this, it is so incredibly tempting to look at that 69% improvement rate, to look at the lack of severe side effects, and declare that we've found it. The miracle breakthrough for end-of-life care.
We have to be careful there.
We do. We need to put our scientific lenses on and pump the brakes, because the researchers themselves are very clear. Do not hype these results.
We absolutely must pump the brakes. This is the reality check portion of our analysis. We cannot overstate what these numbers mean because of how the trial was designed. This was an open-label, single-arm trial.
Explain to the listener why those terms are so crucial here.
A single-arm, open-label trial means there was no control group, there was no placebo. Every single patient, every doctor, and every researcher knew exactly what was being administered. Everyone in that room knew they were taking psilocybin.
Wait, let's look at the sample size, too.
Yeah.
I mentioned earlier that 69% improved, but that was 69% of the 13 people who actually finished the 3 weeks.
Right.
17 started. What happened to the other 4?
Well, 2 of those patients had to withdraw because their underlying terminal disease progressed too rapidly, and 2 withdrew simply because the drug wasn't working for them, and they needed to pursue other end-of-life options like palliative sedation or medical assistance in dying.
It's a sobering reminder.
It is vital to acknowledge that this is not a universal miracle cure. It did not work for everyone.
And for the 13 who did finish, how much of that improvement is actually the drug? I mean, if you're a patient at the end of your life, you're likely desperate for relief.
Absolutely desperate.
And a doctor hands you a pill derived from magic mushrooms, a treatment that is heavily publicized, culturally celebrated right now. You want it to work so badly.
This raises an important question, and you've hit on the most significant limitation of the study, the expectation effect.
The placebo effect, basically.
Exactly. The psychological desire for relief is immensely powerful. The belief that this novel treatment will cure your death anxiety can genuinely manifest as a measurable reduction in anxiety on a self-reported questionnaire.
So their mindset actually changes the data.
Yes. Without a control group, we cannot definitively separate the pharmacological effect of the psilocybin binding to serotonin receptors from the psychological effect of simply receiving a highly anticipated compassionate care intervention.
So what does this study actually prove if it doesn't prove it's a cure?
It proves feasibility and safety. It's preliminary, phase 2 data. It demonstrates that you can take a highly vulnerable, heavily medicated population, give them an escalating microdose of a serotonergic hallucinogen, and they won't suffer severe physical or psychological harm.
It essentially gives the scientific community the green light to take the next, much harder step.
Exactly. It justifies a massive, double-blind, placebo-controlled trial. A trial where neither the patient nor the doctor knows who is getting the microdose and who is getting a sugar pill.
That makes sense.
That is the only way we will know for sure if the chemical compound is doing the heavy lifting or if it's the expectation. We are at the very beginning of the scientific journey, not the end. Psilocybin is not ready to definitively replace traditional clinical care tomorrow.
So as we pull all these threads together, what is the big takeaway for you listening to this right now? For me, this study is a fascinating glimpse into a shift in medical philosophy.
It really is.
It represents a growing, vital recognition that treating physical pain at the end of life just isn't enough anymore. Standard medicines fall short because they treat the mechanics of the body, but they ignore the profound existential weight of the mind. We can't just sedate people. We have to help them find peace.
And that pursuit of peace brings us to a detail buried in the methodology of this study.
Yeah.
It perfectly encapsulates the tension between sterile clinical science and raw human empathy. Initially, the researchers included a questionnaire in their protocol called the Death Anxiety Scale. It's a standardized clinical tool used in psychiatry to measure exactly what it sounds like, a patient's fear of dying.
Right.
They wanted hard data on how terrified these patients were. But midway through the trial, the clinical team had to completely remove that scale from their protocol.
Why did they pull it?
Because the patients found simply answering the questions too agonizing.
So what does this all mean? When we strip away the hype, what is the actual utility of this research for the medical community?
If we connect this to the bigger picture, the trial is a deeply necessary foundational first step. It successfully proves that you can administer escalating microdoses of psilocybin to extremely frail, dying patients without causing severe physical harm. What it absolutely does not prove is that microdosing is a guaranteed cure for end-of-life distress. The data is simply too noisy, and the study designed too vulnerable to bias to draw definitive conclusions.
Right.
It merely opens the door, proving that we urgently need large-scale, placebo-controlled trials to isolate the actual chemical benefits of the drug from the immense power of human hope.
Thank you for joining us on this deep dive into the source material. We'll catch you on the next one.